Uh, the next photograph is also somebody that I know. I have several students who have started speaking. It's sort of, so it's come to a point where I should stop. But anyway, I think the CKM word itself is incorrect. We should call it CKLM, because the most important pivot in this is the liver. I have enough conflicts of interest to not let me speak. So let me talk about what we can do about this. First is, just like we started calling India the diabetes capital of the world, everybody wants to call it obesity capital of the world. But I'm just going to give you a very simple way to think about obesity. Several years ago, Dr. Mohan and I wrote an editorial on how we need to start moving from diabetes care to metabolic care. The seeds of this discussion were based on a conversation that I had with Dr. Eugene Braunwald. I consider it out of the several ways God has been kind to me, because there's no other way to describe it other than his immense kindness that I got to meet these people, that I ended up having a 45-minute session with Dr. Braunwald. And he was talking at that time about how you need a new generation of physicians who handle metabolic health. And in fact, that's why, I keep talking to people about the need to thinking about metabolic medicine rather than diabetology or diabetes, or now today's curve about obesity. But the important thing to remember is, if you look at these the demographic charts of any country, you will find that obesity precedes diabetes by at least a decade. But with the Indian context, and again I get very worried when people talk about Indian context, the important thing to understand is that the traditional Western definitions of obesity that include these numbers do not hold true, because our BMI needs to be 23 and not 25, and certainly not 30. Second is, irrespective of the BMI, a waist by hip ratio of more than 0.5 needs to trigger evaluation and therapy. So for those of you who are interested, I haven't put it here, if you look at this month's edition of the IJCMD, we have written a second editorial. Dr. Mohan, myself, Shashank and others have written an editorial talking about the need to simplify our definition of obesity, where we are talking about a BMI of 23 plus a waist by height of greater than 0.5 is obesity. A BMI of less than 23 with a waist of greater than 0.5 is metabolically obese normal weight. And any other category that really doesn't exist. We keep talking about this, that. In the Indian context, somebody who has a BMI that is high but no metabolic obesity, that incidence is less than 1.8%. So clearly, what we really want to be doing is to understand the simplicity required in addressing our population. So you don't need anything fancy. I'm taking a couple of minutes to let that noise settle, but also for us to reinforce this particular concept that for Indians, BMI is 23 and above. The waist by height is greater than 0.5 is high. And please do not waste your time on any other investigation. Most of our patients don't need body composition analysis. They don't need DEXAs. They don't need all the gym stuff that is being done. And we've added a third layer to this. Instead of the grades and stages and all the complexities that the EOSS and others that MNCs try to push onto us, simply think about it one way. Obesity with complications, obesity without complications. Obesity with complications, you can trigger, lifestyle and exercise without complications. With obesity with complications, the complications are only 4. Metabolic, vascular, mechanical, psychological. Metabolic is diabetes or pre-diabetes. Vascular, cardiovascular, MAs, HFpEF, the others. Mechanical, arthritis. Remember, 40% of arthritis surgeries can actually be stopped if you lose weight. And I'll talk about the WOMAC score in a minute. Lastly, psychological. So, obesity, 23 plus waist by height of more than 5. Second, if that is present, see if there are complications. If there are complications, trigger therapies. So with that, let me move on to pharmacotherapy. Why should you treat obesity? To prevent complications. I'm not in the aesthetic business. There are other people for that. How can I talk about aesthetics? So I'm not in that business. So I'm in the health business. And the reason that we treat patients with this thing is obesity causes complications. Diabetes, liver disease, heart disease, arthropathies, psychological impact. Right? So, in this, till 2015, the best therapy for obesity was metabolic surgery. By the way, you may not like it, but I will tell you the best therapy for diabetes is also metabolic surgery. There is no other therapy that will reverse diabetes that this does. And why is it that we couldn't do it with medications? Simply because either our lifestyle or our medications were not powerful enough to lower weight to an extent that will reverse complications. We were giving Uppu Kuchappa weight loss, 3%, 2.5%, 5%. Metformin was our weight loss drug, right? So clearly, what we realize is that there is a continuum of weight loss that creates benefit. The greater the weight loss, greater the benefit. So at 5%, you will see glucose is coming down by 0.7 to 0.8. But at 15% of weight loss, you will see glucose is coming down by 1.7 and 1.5. Why is that? This is very, very simple. And this is something we learned from a direct study. I will get to the Novo slides, don't worry. We learned that when you lose 15% of body weight, why is this 15% interesting? You lose 30% intra-abdominal fat. So when you lose these medications, we are so hooked onto the BMI, we don't realize what really happened. I'll show you the data. That the waist circumference is almost the first thing to come down and is at least partly responsible for the benefit. So it is not the actual reduction in fat, but the greater intra-abdominal reduction in fat that you're seeing that is causing the benefit, right? So remember I said 15% weight loss is 30% intra-abdominal fat. 15% weight loss is 30% intra-abdominal fat, is 66% intrahepatic fat loss. When you lose 66% of intrahepatic fat, that means there is no diacylglycerol in the liver. When there is no diacylglycerol, there is no insulin resistance. The story ends there. Then I'll talk about other things. So, how does this work? First, let me tell you, how do you get obesity? You get obesity when the needs for you to have a reward exceeds your body's homeostatic mechanisms. Why do you get obesity? Because I like to eat, and my need to eat overcomes my body's natural mechanisms that will prevent me from overeating. When the reward systems overtake the homeostatic mechanisms, that's what happens. So how do you get reward? If the reward systems did not exist, humanity would not exist because none of us would have kids. Yes? It's very simple. Whether it is maternity, whether it is sex, whether it is power, these are all reward systems. Reward systems are driven by two hormones. The first, you have to like something. The second, you need to be motivated to go get what you like. ரெண்டும் இருக்கு. தூரத்துலேருந்து பார்த்து சந்தோஷம் அழகாக இருக்குன்னு சொல்கிறது வேற விஷயம். அதை போய் ஸ்டாக் பண்ணி எடுத்துன்னு வருது இல்லையா, அது வேற விஷயம். That's where you get into trouble. So liking is mediated by opioids. Wanting and being determined to get it is determined by dopamine. So for many years we thought that the GLP-1 RAs, they have direct receptors, which they do in various parts of the brain. These drugs go there and then they reduce weight. Illa. If this whole blood-brain barrier theory is complete bunkum. There are only two areas in the periphery of the brain where they can have direct effects. What we know now is, and hopefully another day I'll give you a talk on how NASH hormones have a very, very complex interaction with both the gut microbiome, the vagus, the enterohormonal network, and project to these various reward systems. So what your hedonic input, so when I say hedonic input, Indians get it much better than the West. We have Indriya, Mana, Chitta and Viveka. Indriya is your senses. When you see it, your mind reacts to it and says, I like it, I want to take it. Your intellect tells you, you know what, it's bad for me, but it's overruled by the senses and says, go ahead and get it. The last segment is what most of us, including me, and except for a few emancipated people, don't have, which is Viveka. The power to discriminate and say, no, this is bad for me, I won't take it. But ultimately, that's what you want to do. So, the idea of this is, you need to dissociate the sense of reward from the sense of eating. And guess what GLP-1 RAs do? Yes, they have homeostatic effects. Yes, they have other effects. Their most important effects is they dissociate food from that reward system. Adan சாப்பிட்டா மாதிரியே இல்லை டாக்டர், சாப்பிடவே பிடிக்க மாட்டேங்கிறது, பார்த்தாலே துவேஷமாக இருக்கு. Exactly. That is why some of these drugs are useful in addiction. எல்லாம் ஒன்று தான். The same pathways have been repeated for centuries and we have overruled them. Okay? So now you know how it works. Okay? So how does semaglutide work? We know how it works. Does it work? All these studies say it works. I'll go just quick through this. Weight loss, the greater the weight, the dose, greater the weight loss. At 2.4 milligrams, around 14 to 16%. Now, the ones that you see with these 20% numbers with semaglutide are from the step-up study, which talk about 7.5 milligrams of semaglutide. That is probably vomiglutide doses, right? So, about a third of patients will lose more. There is no way to say who will lose more and who will lose less. There are people who have talked about polymorphisms, other. The truth is, we don't know who will respond. Pottadan theriyum. Next. This is the most important part, that the weight loss starts early. The waist loss starts even more early, and I will show you very interestingly, the off-target effects start even more earlier, meaning that we need to distinguish between the direct effects of this drug, which are quite considerable, but the off-target effects of this drug seem to be even more substantial. And I'll discuss this as we move on and we close through this. These are the weight loss benefits, right? But what is interesting is this, that these are not diabetic patients. These are obese patients who are not at high risk, who have not had a cardiac event, who are at high risk for a cardiac event but do not have diabetes. Remember, diabetes is almost like a coronary risk equivalent, right? If you see the SELECT study, there's a 20% reduction in CV outcomes, but what is important is this part, that at 6 months, there is already a 31% reduction in MACE. And I can tell you at 20 weeks, there is already a reduction. So, this is not explained by the amount of weight loss that you have gotten. This is an off-target effect, right? So, when Shruti and of course everybody else talks, you'll understand that the one thing that we don't know about these drugs and the follow-on synthetics is, will they have the same effect? We don't know. I told you in this thing. All right. And this is, because it's an off-target, it's independent of every other factor. Whatever be the baseline CKD, whatever be the HSRP, whatever be this thing, the MACE is reduced. Second, and what is interesting is the renal effect. Now the flow study with semaglutide and the select study with a higher dose all showed that there's a 22% risk reduction in renal events in MAR. Now what you want to realize is that when it comes to renal effects and heart failure, with HFrEF and renal failure, SGLT2s are more powerful, but increasingly the GLP-1 RAs are an evolving pillar of renal therapy. I want you to know that for the last 10 to 12 years in ESRD, my go-to drug has been originally dulaglutide. Takes off the insulin, very safe in that group, this thing. And now, with the MAR events that you're seeing, I'm using a lot of SEMA. Okay. Now, Novo can close their ears because I will talk about the Essence trial because since they don't have an approval, they just want me to talk about the SELECT and the MASH. But remember, the Essence trial is one of the pivotal trials that you will see in fibrosis. To me, the liver is the center of this universe, of the metabolic universe. When you look at all these drugs, first remember silymarin, weismarin, vitamin E, where are you spending? Udox, Udiliv, ubetacolic acid. Everything is glorified placebo. Vitamin E can, in doses of more than 400 international units, increase cardiovascular outcomes. So please don't give that drug. SGLT2 inhibitors will improve steatosis, will improve steatohepatitis, and may prevent progression of fibrosis. Pioglitazone, 3. I have done studies where you combine the two and the FIB-4 scores come down. Tirzepatide prevents, reduces steatosis, reduces steatohepatitis, may prevent progression of fibrosis. No evidence on reduction in fibrosis. There are only 2 drugs that have evidence on reversal of fibrosis. Resomelagon and then semaglutide. Semaglutide reduces steatosis, steatohepatitis, and prevents progression of fibrosis and regression of fibrosis from F3 to F2. This drug has not been evaluated for F4 to F3. Must remember this, right? But clearly, and remember that this is at a 2.4 milligram dose, not at 1 milligram, because remember we had the liraglutide trials that didn't show much. Okay, so to me, this is the most important, and I always find it surprising that the drug companies don't talk about it. 6.3 inches is 20 centimeters. That's me like becoming, somebody very young, right? And I think some of you would have heard my talk about NASH and longevity. These are probably the truly new longevity drugs that are available. Okay, so I'm not a big fan of this, but I'll just tell you that versus tirzepatide, if Lilly does that study, you will find Novo's data better. If Novo does a study, you'll find Lilly's data better, whatever you want to say. But what is important to understand is that, let me stick my neck out, because if you look at the SURPASS trial, which is compared against dulaglutide, in my view, and I did have a chat with Dr. Knox, so I can say this, that the results are a little underwhelming, because for the amount of weight loss that you saw in SURPASS, and the A1C is down to 5.6, you would have expected better. But what is the unknown is the effect of GIP on the heart. We know the effect of GLP on the heart, but most of us are worried about the effect of GIP on the heart. So it's quite possible that we need more studies to see how this works out. I'm just going to tell you though that we have some new data on 7p MACE with tirzepatide, which looks very, very interesting, which means that on a head-to-head basis, these drugs are probably the same. Okay. So, when do you use this? Now, I have so much fun saying this. If you look at the diabetes 2026 algorithm, guess what drug is missing in the first line? Ellarku pidicha drug. Metformin. Don't see it anymore. I'm so happy. I'm just joking. But I just want you to say that as time evolves, we also need to பழைய பஞ்சாங்கத்தை பிடிச்சின்னு உட்காந்துருக்கக்கூடாது. Right? பழையன கழிதலும் புதியன புகுதலும் அடுத்த ரெண்டு லைன். Right. So if you understand that, it's not that we hate one or other drug, but as Dr. Moses said, never hold on to stocks or your hypothesis. When it's there, sell it. So what you really want to be doing is understanding where the science has gone. The science for this decade belongs to SGLT2 inhibitors and GLP-1R. Right? And how do you choose between tirzepatide and semaglutide in obesity? One, if I want greater weight reduction with the lower doses, I choose tirzepatide. If I want obstructive sleep apnea therapy, I would use tirzepatide because it's approved for its use. If I have a patient who's had a myocardial infarction, who I want to improve ASCVD, I would use semaglutide. If I have a patient with HFpEF, both of them are the same. If I have MASLD, I would use semaglutide. What I don't see in this is this fantastic new data on osteoarthritis. If you give semaglutide in patients with osteoarthritis, there is a big reduction in the WOMAC pain score. The WOMAC pain score is improved so much that if you're planning to have an orthopedician for a son-in-law, change your mind. He won't make any more money in the future. Right? What is interesting is that this drug is not just lowering your pain. Cell Press had an article that was published this month. And what it shows is that it improves cartilage structure. So, as I said, these are the new NUSH therapies. Okay? So with this, I'm going to hand over the stage to someone who's exceptionally good, and we'll make sure that you don't sleep for the next 20 minutes. Thank you so much.